All right, thanks very much for the introduction. My name's Rob Flavell. I'm a radiologist and nuclear medicine specialist at the University of California in San Francisco. And I'm here today to share with you some of my experience and some interesting cases that we've had, and in particularly using new PET imaging and theranostic approaches in the management of patients with prostate cancer. And I'm going to present some of the information, things we know from the literature, and I'm also going to present these cases in a way to kind of provoke discussion, because I don't think everyone knows all the answers of how to use the information gathered from these scans or how to use these therapies best. We're kind of learning it as we go. So we're going to hopefully provoke some interesting discussion. So imaging in prostate cancer is really a very dynamic area right now, and it does play an important role in managing prostate cancer patients. And Dr. Slovin gave a great introduction to this already in the form of like traditional imaging, which includes CT and bone scan, but then also more recently next generation imaging with Fluciclovine, PSMA, etc. So imaging and therapy really are changing very rapidly here. And these new PET imaging and theranostic approaches really are changing the way that we treat these patients. Although we don't really know all the answers yet. What do we do with these spots that show up on the scans? What do we do with these new therapies? Who are the right patients for these therapies? So there's a lot of questions that remain about the best use of these new technologies, and that's something we can discuss further tonight. So just to kind of set the stage for the overall landscape of prostate cancer imaging. So this is a very simplified diagram of the course of disease for a patient who's kind of a bad actor prostate cancer. Typically, a patient will present to a physician with either a concerning symptom or maybe with an abnormal PSA screening test, and that will yield a diagnosis of prostate cancer at a biopsy. At that point, patients have several options, but if they have high-risk disease, meaning a cancer that's likely to grow and metastasize, they will then typically undergo definitive therapy, and that usually means radiation or surgery. And at that stage, in that initial high-risk setting, there can be additional information gathered from imaging. And traditionally, this has included CT scan and bone scan. CT scan of the abdomen and pelvis to look for lymph nodes, which is a common area of spread, and bone scan to look at the bones, which is another common area of spread. MRI also can be helpful in some cases, looking at the local extent of disease. After that, many patients will undergo definitive therapy, radiation surgery, and in most cases will be cured. However, a significant proportion of patients will recur, and their PSA number will start to creep up again after surgery or radiation, a phenomenon we call biochemical recurrence. When that happens, traditionally, therapies have included salvage radiation, which is kind of empirically radiating the pelvis, because we know that that's usually where the prostate cancer comes back, and also treatment with anti-androgen or hormonal therapies, which are very effective in treatment of these patients. And in this case, also traditionally, imaging has been used, usually CT scan, again, to look for those nodes, and bone scan to look at the bones. And usually after that salvage radiation or hormonal therapy, most patients will then again have a response for a period of time. However, in most cases, eventually that will go on to progress to a phenomenon we called castrate-resistant prostate cancer, meaning it's now resistant to hormone therapies. And in that case, again, CT and bone scan can be used to look for sites of metastatic disease, and that's like we were just discussing. And in these cases, this is really a very dynamic area for therapies, and with a multitude of new therapies, of which I'm going to really just touch on a little bit in our nuclear therapies, the radium and lutetium-based therapies. So there's a lot of new stuff going on in PET imaging of prostate cancer, and really, this is quite a confusing field, even if you're an aficionado in it, and there's been a lot of stuff developed over several years. This talk is not designed to be comprehensive. I'm going to really focus on two main imaging agents, and that includes PSMA, which is this little circle there on the left, and Fluciclovine, or FACBC, the circle on the right. These are probably the two most widely used next-generation imaging approaches right now. Fluciclovine is an FDA-approved agent. PSMA agents are still investigational, and there's many of them currently under development. So as an outline, using a case-based format today, we're going to examine the role of new PET imaging approaches in patients with new diagnosis of high-risk prostate cancer. We're going to discuss the efficacy of emerging PET imaging methods in patients with biochemical recurrence of prostate cancer. And we're going to review the role of new theranostic approaches in castrate-resistant prostate cancer. So kind of three separate topics here. So let's go ahead and start with case number 1. So this is a patient with an initial diagnosis of high-risk prostate cancer. And these are all real cases that I pulled from our medical record at UCSF. So this is a 58-year-old man referred for a new diagnosis of prostate cancer. His brother was diagnosed with metastatic prostate cancer. He underwent PSA testing yielding a value of 23.7. He then underwent a biopsy, ultrasound-guided biopsy by a urologist, yielding a Gleason 4+3 prostate cancer in 13 out of 15 cores. So this is aggressive-looking prostate cancer based on the Gleason scoring and then also the pretty extensive volume of disease based on the number of positive cores. The past medical history, he has some arthritis but is otherwise negative. Essentially a healthy person, no prior surgeries or medications, and review of systems and physical exam were otherwise unremarkable. So his bone scan was ordered and was negative, other than probably some degenerative findings, just meaning arthritis in the lumbar spine, and his CT abdomen and pelvis was also negative. At UCSF, we're doing imaging with PSMA-based agents, and we have a ongoing clinical trial on the use of gallium-68 PSMA PET, so that's what this patient was referred for. So PSMA is a protein that's expressed on the surface of a lot of prostate cancer cells. It's a transmembrane protein, and it's been around for a while, and there's been a lot of imaging agents developed against it. There was Prostasent, was an agent developed probably 15 years ago, antibody directed against the intracellular domain. There's been other antibodies directed against the extracellular domain. What I'm going to be talking about today are these ones here on these small molecule inhibitors. And that's an area where there's been a lot of progress recently. We have small molecule inhibitors that bind to this enzymatic domain. And these seem to be very effective for imaging. So there's a variety of agents under development. They're mostly based on the use of the isotopes gallium-68 or F18. F18 is really widely spread because fluorodeoxyglucose PET is standard of care for a lot of cancers. So F18's, there's a lot of places that have F18. Gallium-68 is a newer technique. It's been approved for use in neuroendocrine tumors that kind of paved the way for acceptance of this, and now it's being spread out into other cancers as well. These agents are considered to be quote-unquote theranostic because you can use the diagnostic agent and pair it with a therapy, which might be labeled with a therapeutic isotope like lutetium-177. And these are experimental. None of these are FDA approved, although there has been extensive clinical trials, mainly in Europe and Australia, and more recently over the last few years in the United States as well. And over the last decade, there's really been just a number of different agents developed. And this isn't really meant to be comprehensive or to have a nuanced discussion about this, but the point is there's many of these agents out there right now, different development in industry, being studied in academia, and really it's not yet clear, shaking out yet, which one of these is going to become the best one to be using in the future. So let's go into what some of these pictures look like. So this is a normal biodistribution of a gallium-68 PSMA-11 scan. When I'm teaching my residents about what the scan looks like, I tell them it looks like the scary clown. You guys see that maybe? The little eyes, and then it's an easy way to remember it. I find like when you're teaching things, the kind of sillier you can make it, the easier it is to remember. So got the scary clown appearance, and then normally in the abdomen and pelvis, you see some uptake in the liver, spleen, kidneys, clearance via small bowel, and then you'll see some in the bladder. So in terms of the, what do abnormal scans look like? Well, here's an example of a patient with lymph node metastases. So we see in addition to those, in the normal distribution, we see multiple additional spots here in the region of the retroperitoneum. And then this patient also has one up here in the neck. These are tiny little lymph nodes. These are sub-centimeter, they're really only a few millimeters in size. but they have uptake of the radiopharmaceutical, and they're in an appropriate location for a prostate metastasis to go to. So when we read these scans, we say this distribution, these are metastases almost certainly. And what does the spectrum of metastatic disease look like in these patients? Here's just 4 cases. Here's one patient who has some lesions in the right aspect of his pelvis. These are actually bone mets. Next case, here is a patient who has metastases in the hilum, hilar lymph nodes, and in a rib. Here's a classic one we see very commonly in patients who have undergone salvage radiation. So we see lymph node metastases kind of in the upper pelvis and creeping up the retroperitoneum. Probably that pattern happened because when they had their salvage radiation, they probably already had micrometastatic disease above there, and the radiation didn't hit it, so it just kind of grew up from there. And then here's an unfortunate example of a patient with a new diagnosis who just had really diffuse bone mets at the time of presentation, and we see these occasionally as well. So this is the type of spectrum of disease we're seeing with PSMA PET. Some other interesting examples. Here's a patient with a single hilar lymph node metastasis. This was confirmed on endobronchial ultrasound-guided biopsy. And here's just a kind of a really telling case of the enhanced sensitivity of PSMA PET. So here's a patient who underwent a bone scan. This bone scan is abnormal, and I think any of the nuclear medicine docs in the room would call it abnormal. There's multiple vertebral bodies involved. But if you look at their PSMA scan, really the distribution of disease is much more extensive than you'd expect to see on the bone scan. This patient really actually has a pretty significant volume of disease. We're just not seeing it very well on the bone scan. And we do see this in a subset of cases. So that's kind of the good of PSMA. But as we've been going through it and learning about these scans, we've been learning about some false positives and normal variants that actually can make our lives considerably more complicated. And if any of you guys out there in the audience are on the receiving end of these reports, read by people who are still learning how to do them, you may see these kind of things. So this is, I call this taking the PS out of PSMA. So one thing we've learned is that PSMA is actually expressed in a lot of things that are not prostate cancer. So here's an example of a patient who has a mass along the lesser curvature of their stomach. It's kind of an exophytic mass. So this turned out to be on biopsy to be a gastrointestinal stromal tumor. So, and the reason why we see these is because the PSMA gets expressed on neovasculature and tumors. So if you're seeing a PSMA uptake in an area that's really kind of unexpected, consider other tumors. Here's an example of a patient with a single bone lesion, and this is one of my least favorite situations when I'm reading out these scans. So this was a patient with a new diagnosis of high-grade prostate cancer, has a sclerotic lesion in his vertebral body, pretty intense uptake of the tracer. So at the time, we weren't entirely sure what to do with it. We recommended an MRI. And then on the MRI, there's this single lesion. The neuroradiologist felt that this looked more like an atypical hemangioma rather than a prostate cancer metastasis. So what did the urologist do about it? Nothing. He removed the patient's prostate, and the PSA dropped to 0, and it has not recurred since. So this is an example of a false positive, and one of the themes here is beware of the solitary bone lesion on these scans because there is a high rate of false positives. All right, so so let's go on. I've got a couple other interesting cases taking the PS out of PSMA. Here's another patient, newly diagnosed prostate cancer. PSMA PET showed primary tumor, no metastases. I've got the arrows on it there. This patient had an incidental finding, which found some uptake at the base of the tongue. We looked in the patient's chart. It turns out this patient had a history of head and neck squamous cell cancer with unknown primary post-resection. So we recommended an ENT consultation. They took a look and they confirmed a biopsy-proven base of tongue squamous cell cancer. So again, in the tongue, we're not going to be suggesting that this is a prostate met. We have to use some common sense when we're interpreting these scans. Again, if PSMA is expressed on other things, so if it's an unexpected location, consider other tumors. Some normal variants we're coming up with, this is one you may very well see if people are just learning to read the scan. I know we were calling these positive early on until we really became aware of this, is these ganglia. These are tricky because these are in spots where you can commonly see prostate mets. So these are right next to the spine and in the retroperitoneal regions. So these are sympathetic ganglia. They have uptake of the tracer, and these are normal. And this is my least favorite of all, is the presacral ganglion. This is right in front of the sacrum, very common location for prostate nodal mets. So very, very difficult to distinguish sometimes between a nodal metastasis and just a normal finding.
So how do you determine it?
So things that would favor as a ganglion would be symmetric uptake, because they're paired on each side. And corresponding abnormal finding on the CT scan. But to be honest, I don't think we really have any other way of being 100% sure. So I'll include a differential. I read a case like this yesterday, actually, where it was, I said, it's pretty asymmetric. There's a little nodule there, but it's right where the ganglion would be, so it might just be a ganglion. So to summarize, what we know about PSMA scanning is it does have good sensitivity and specificity for lymph node metastases. And what I'd like to add to that is beware of the solitary bone lesion. We see common expression in other tumor subtypes, both benign and malignant. And the cervical and stellate ganglion uptake is something to be aware of. So let's go back to our case. So this is, again, 58-year-old man, new diagnosis of prostate cancer, high PSA, Gleason 4+3 tumor, 13 of 15 cores, underwent his gallium PSMA PET. And what did we find? So here's this patient scan. Again, scary clown appearance. And I'll first of all just point out the patient's primary tumor, denoted here with the arrow. In this case, you can actually see it on the CT scan. There's some faint enhancement in the region, intense uptake. No one's surprised the tumor's there. They already knew it was there at the biopsy. But we saw some additional findings as well, which is there's multiple spots of uptake here in the thorax and neck. And this is interesting because I like this slide because it shows two things on the same slide. One is this benign cervical ganglion uptake over here on the left. But then this is over here in the supraclavicular region. That is not a normal location for a ganglion. So that's where a lymph node would sit. So that's a lymph node with increased uptake in the supraclavicular region in the neck. In addition, there were multiple other lymph nodes in the upper mediastinum that had increased uptake. They're not very big. They're all only measuring a few millimeters. So how did we read this study? Well, we said findings consistent with the patient's known prostate cancer. But then in addition, we got multiple lymph nodes in the supraclavicular and mediastinal regions suspicious for metastatic disease. So what do you do with this information now? So fortunately, this case was nice in the sense that we had something that we could readily biopsy. That little lymph node up in the neck is readily amenable to percutaneous biopsy. So this patient actually did undergo a fine needle aspiration of the lymph node because, that, as I said before, this could be another tumor. And however, this did turn out to be metastatic prostate cancer. I think what they did, at least as documented in the note, was they gave the patient some options. The two ones that were mentioned in the note was an aggressive approach,
right,
which is prostatectomy followed by radiation therapy with consideration of additional surgical and or radiation management of these documented supraclavicular and mediastinal lymph nodes. And then the second would be start with the hormonal therapy, as you discussed, reassess after an initial round of hormonal therapy. And the patient opted for number 2. So it's interesting. We do have some follow-up on this because this patient's scan happened a couple of years ago. This is one of our earlier scans. So again, he was diagnosed with this high-grade tumor. He underwent the PSMA PET with positive uptake in the supraclavicular lymph node, and then that was biopsy confirmed in March of 2016. PSA was rising quickly. We're looking at like a doubling time of probably 6 months or less here. So he was started on Firmagon actually that time. Had a nice PSA response. So I think this is an interesting case because first of all, it demonstrates the sensitivity of the imaging study, and it also demonstrates sort of the complexities of managing a patient in light of that information. All right, so let's talk a little bit about the accuracy of the PSMA. So this is, I got some actual studies to back up the statements that I was saying earlier. So this study of 130 patients, newly diagnosed intermediate to high-risk prostate cancer. So this was a retrospective study where imaging findings were correlated with pathology. So 41 of 130 patients had lymph node metastases in this study at time of surgery, and the sensitivity and specificity and accuracy of the Gallium PSMA PET was 66%, so 66% sensitivity, not that great, right? High specificity of 99%. And the sensitivity and specificity were superior to conventional imaging. Another similar study, 30 patients, 27 who were high risk, 3 intermediate, prospectively imaged with Ganglion PSMA PET prior to prostatectomy and lymph node dissection. 11 out of 30 had lymph node metastases, and the sensitivity was 64%, specificity of 95%. And you might think, well, why are we missing this? I was just saying how great PSMA was. Well, what they're missing are small lymph nodes. So these are, on average, what was missed was lymph nodes around 2 to 3 millimeters. So while this is probably very sensitive, the most sensitive test we have available, it's still missing a significant proportion of micrometastatic disease. So just something to consider. So to summarize the discussion of PSMA and newly diagnosed prostate cancer, it's specific and probably the most sensitive imaging method for detecting metastatic disease in newly diagnosed intermediate or high-risk prostate cancer. The sensitivity is still moderate, remember that, for micrometastatic disease. And the role in changing management and benefit remains unclear, although probably reasonable roles to investigate in the future would include guiding radiation planning and identifying distant metastatic disease, whether high volume or low volume, as in the case we were just looking at. So with that, we'll switch gears and talk a little bit about biochemical recurrence. This is Mr. B. He's a 67-year-old man, history of Gleason score 4+3 T2C prostate cancer. He underwent radical prostatectomy in 2009. In 2014, he presented with biochemical recurrence, for which he underwent salvage pelvic radiotherapy. In 2017, had a second biochemical recurrence, PSA level 0.37 nanograms per ml, and conventional imaging was negative. This is a case that was provided to me by some of our colleagues at Loyola University, Dr. Saver Baruch. And so what would you do next for this patient?
So this is now a biochemical relapse after surgery or radiation. So one could make an argument about doing a PET choline scan. The only issue that has been coming up is that some people would argue you really should have a much higher PSA, at least greater than 2, for it to really be accurate. So again, people read things. I've had people, come over to Memorial when they couldn't get a choline PET scan somewhere else, only to find that it led to more complications because they couldn't interpret the data.
So this patient, he was assumed to have distant disease and was considered for hormonal therapy, but at first he was referred for a F18 Fluciclovine PET CT scan. So here's this patient's imaging. So he had a very, very faint focus of uptake, tiny little presacral lymph node with very faint uptake. And that was the only finding on the scan. It's a single presacral lymph node. It is a pretty suspicious location, so you'd have to be worrying about a metastasis in this situation. And, what would you do in this patient?
So why, you have a guy that has something up in the supraclavicular area, nothing in the pelvis, and you're calling this suspicious compared to this?
Yeah, because the location.
Well, in this case, presacral nodes with prostate.
But he's saying it's asymmetric rather than symmetric in this case. I mean, I agree with David. This is cheap relative to the other one. The other one was on the spunky side, but this one, you can say, wait it out. What's the rush?
Yeah, I think that's a reasonable. Sounds like a reasonable plan for management for this patient.
So, the question is, does it really matter one way or the other if it's positive or negative? Is an intervention going to matter? Would it matter if you waited a little bit? Do you still think you can cure the guy? I don't know what his pathology was. You just said he had a radical prostatectomy. Did he have seminal vesicle invasion, positive margins?
Yeah, sorry.
Various other things like that. But the point is, this is a good case because these oxymum scans are being done left and right on men like this. We did like 6 2 weeks ago, and we're getting scans back like this with people that have elevated PSAs, and we think they're real. And I think we've got to do something like we've got to biopsy them to prove it. Another thing you can do is give the guy hormone therapy, short term, and repeat the scan, see if it goes away, if it stays there, whatever. Those are options. There's a lot of things to do. But the patients I deal with, I can tell you right now, once you find something like that, you've uncovered something, and they want you to investigate it and do something about it.
I think
Cat's
many
out
of
the
us
bag.
would argue that the natural history of biochemically relapsed prostate cancer can be very long. It could be several years before you see any change in imaging. So one could make an argument to sit on this guy for a while and just let it play out with appropriate imaging periodically.
There's three things that get you into trouble with biochemical failure: failing early within the first year, higher grade cancers, and PSA doubling time. The most potent is PSA doubling time.
So my question is, are these imaging modalities reusable? Do we have data to suggest that you had an Oxyman scan, 6 months ago, that you should get another one?
Yeah,
No data on treatment response. So that's my concern is I think cases like this are very common. And Dave brings up a great point that you're going to see a ton of cases that report these types of nodes. You're not going to see the images. You're just going to see a report that says there's a presacral node that's highly suspicious for metastatic disease, not knowing what it means. And and a lot of places aren't actually putting semi-quantitative parameters in their reports to give a sense of how intense that activity is. So I think this is an area that really we need to be careful with, and no one's really sort of defined that a little better.
Now you're whining. So look, okay, you got something new and exciting, and you're shooting it down. Do we have follow-up imaging? No, it hasn't been around long enough. Let's do it. Let's see it. Let's take a guy like this and re-image him in 6 months.
I agree. I completely agree. We're not trying to shoot this down. This would be not beneficial for our society.
Yeah.
But let's proceed with caution. Yes, you're right.
I think the really interesting thing about having this discussion is, there is really a lot of options for these things, and a lot of these questions just aren't known yet. I mean, this scan was only approved about, a little over a year ago, right? So what are we doing?
should
with
be
this
happy.
scan? It's great. In our field, we're very happy. This is sort of keynote stuff at all our society meetings and everything. So let's talk a little bit about Fluciclovine. So this is not targeting PSMA. So this is an amino acid analog. So it gets taken up by amino acid transporters. This is approved by the FDA for biochemically recurrent prostate cancer. Unlike a lot of other radiopharmaceuticals, it actually gets rapidly exported from the cell, so you have to image very shortly after injection. So we're usually injecting the patients while they're lying in the scanner. It's highly sensitive for prostate cancer recurrence, and this is actually a serendipitous discovery, as it was actually originally developed for glioma. The prostate cancer was a kind of an incidental finding on a glioma scan, and then that's how this whole line of research got started. So what do these scans look like? Well, the normal distribution is uptake in liver, pancreas, muscle, and bone marrow. So this is what a normal scan will look like. The really bright stuff is the liver and the pancreas. And so what sort of things are we typically seeing on positive scans? So on the left, we have the maximum intensity projection. Looks pretty unremarkable for this patient. Has one additional finding here, which is a tiny little retroperitoneal lymph node metastasis. You can see increased uptake here, aortocaval lymph node. It's sub-centimeter lymph node. These are the types of things we're picking up with this scan now. I've got the arrows on it. Well, you can use some positive diagnostic criteria for looking at the lesions, doing some quantitative analysis of it to give us more confidence. So this is useful information to be including in the report for the reading physicians to lend credence to what we're saying. And then what do the positive scans look like? Here's a few other examples. So here's a patient with biochemical recurrence with a prostate bed recurrence. This is a sagittal view of the scan. And then we got a single separate patient here with a single internal iliac lymph node metastasis. And then we got one in the right pubis. So these are 3 different patients. Nice review article here from David Schuster at Emory. Here's some interesting example. Again, false positives, normal variants. We're learning all these as we're going with these scans. So A in the top left, there's some uptake in extra axial mass in the head. So it's a meningioma. B, we have some uptake on the skin. This is just skin inflammation on exam. Here we have some uptake in lymph nodes in the inguinal region. So this is ringworm. And then on the bottom right, we got single uptake in the skull. This turned out to be an osteoid osteoma. So some nice examples. So returning to this case, so what did they actually do with this patient? So we had the single uptake in the presacral lymph node. So this patient actually did undergo localized radiation to the node.
Really?
Yep. As I said, this is not a case of mine. I had to go outside to get an Axumin scan because we do so much PSMA, so we don't have a lot of good Axumin examples. And after this patient got radiated, his PSA dropped undetectable. So we treated the number. We don't know in the long run if we treated the patient the right way, though. So here's another biochemical recurrence example. So this is a 68-year-old man, history of prostate cancer, rising PSA after radical prostatectomy. Here's a little more detail. This guy had a radical prostatectomy, Gleason 3+4 tumor, had a positive posterior margin, no positive lymph nodes.
David, would you, at PSA 4.2, would you have had some action on that gentleman before it went to 7.4? Because I know you were advocating for maybe 0.5 as perhaps a PSA that, or more that might be reasonable for a surgical intervention.
Just very briefly, there's a lot of controversy about overdiagnosis and overtreatment and how you deal with it. And the issue is also 90% of PSAs in the United States are ordered by family practice doctors. So if you're going to start with the education, it has to be with them. We confuse the hell out of them. We talk about PSA velocity, PSA density, age-specific PSA, PSA cutoff of 1.5, 1.4, PCA3. We have this test. We have 4K, and we have phi, and they go, oh my gosh, they need a simple cutoff, and we've actually shown 1.5 sort of is a good cutoff for them to remember. 70% of men have a PSA less than 1.5. 1.5 to 4 is a gray zone. That's an area where the patient needs to be evaluated. That's where we have great new tests, molecular markers that help us determine who should be biopsied. We don't want to biopsy everybody. We want to find cancers that are significant. When you go to your family practice doctor, Susan, and he does a blood sugar on you and your blood sugar is elevated, do they start you on insulin? Do they start you on metformin? No, they do an A1C hemoglobin. So it's a next step. We have a next step to PSA to do it, to find it. This guy has a PSA of 4.2. I think that at 68 years old, I would have done a biopsy or one of these tests back then. And he's gone up 7.4 in a year. That's quite a hike, actually. It doesn't seem like much, but it's quite a hike.
All right. So this patient underwent his prostatectomy with positive margin and had a residual PSA of 0.34 on his first measurement after surgery.
Not good. Remained
persistently elevated. Then he subsequently underwent salvage IMRT in 6 gray, 37 fractions to the prostate bed. Had a PSA response with it dropping somewhat, but not to undetectable, and then starting to creep back up. Has some other past medical history and things. We can kind of skip through this. None of it's particularly germane to the case, to be honest, just for the sake of time.
But he has an ugly family history of father with colon and somebody with breast. So
that's true. Yeah, there is a significant family history of cancer.
So you start thinking on the Lynch side of the spectrum.
So his labs were unremarkable in the PSA. So he had a CT, abdomen pelvis was normal, sodium fluoride PET CT normal. So it's an interesting case. So this patient was referred for Ganglion PSMA PET CT, and sure enough, he had a finding. In this case, got a single focus of uptake. Here it is.
And let me guess. Single focus, they probably didn't biopsy, they zapped it.
That basically summarizes what happened with this case. So this is a very interesting case because I have a companion case which is not in here. So this patient underwent exactly what you said, which is this is very difficult to biopsy because there's no CT correlate. So where are you going to aim your needle? It's not
so if
easy.
There's no CT, you're a radiologist. So, but if there's no CT correlate, do we take it on faith? Because usually people are very adamant that what you see on a bone should be seen on a CAT scan.
Yeah, usually in this situation, what I would do, if I had read this scan, I would have recommended MRI because in that case, what you'll usually see is they'll find an enhancing lesion. And I have that was not done in this case. I do have a companion case where that happened, and they saw a 4 millimeter focus on the MRI, and then 4 millimeters, who cares? Then that patient got a follow-up MRI 6 months later, and it was 8 millimeters. So that's a metastasis. But
Susan, I'm going to make the argument that seeing it on a CT usually occurs later than seeing it on a PET, generally, because on CT you need to see structural changes with the bony matrix, which is going to require more cells and more time and more turnover to see it on a CT.
But MR would give you at least marrow changes earlier.
Exactly.
So interesting. So yeah, we said a single focus, suspicious for metastasis. Probably recommend an MRI for this patient. So how would you manage this patient? I think probably, as we've discussed, most of us would probably watch this patient, right, or get correlative imaging. What's the rush? The PSA is 0.06. So,
I agree.
So the patient did opt for an aggressive path of therapy, including salvage androgen deprivation in conjunction with stereotactic radiotherapy.
I mean, sometimes people would do a radiofrequency ablation on that one if it's doable. We have one patient who, for whatever reason, every little bone met, all his disease is right in the pelvis, and IR has just been doing nothing but that. Every time PSA goes
Yeah.
up, another met shows up, it goes away. But that's
That's a great
his
option.
biology. But
Yeah.
but it's not for everybody. So what happened? He got radiation.
So-
Go ahead.
So you got
Yeah,
Lupron and
Lupron
radiation. So the story's kind of murky. Is PSA dropped undetectable? So let's discuss a little bit, how does PSMA work in biochemical recurrence? So this is a study of 150 patients with biochemical recurrence who underwent PSMA PET. This was from our institution. So the referring physicians were answered a survey regarding what there would be planned management without PSMA study. And then of these patients, 103 of 150 had a site of disease detected on PSMA PET. And based on survey results, at least 53% of patients would have had a major change in management based on the PSMA study. And similar results were also reported in a larger Australian study. So at least there's a suggestion that these results will cause change in management. We don't know. What we don't know is, does this change in management help the patient? And that's gonna be something that's gonna be a much more difficult question to answer.
Or harm the patient.
Yep. Absolutely. So here's another study, 117 patients, hormone-naive biochemical recurrence. Here's showing the detection rates by PSA. So from 0.2 to 0.5, you get 65%, 0.5 to 1, 86%, 1 to 2, 86%, and greater than 2, about 100%. My opinion is this probably is a little bit inflated, but I can tell you a little bit about my experience with detecting sites of recurrence. So where are these things normally found? Well, many of them are going to be places you're going to be very much expecting, like pelvic lymph nodes, retroperitoneal lymph nodes, or bones. You do have some surprising findings of solitary recurrences in the lungs, mediastinal lymph nodes, and things like that. So there are surprising findings that come out of these sometimes. So the probability of detecting disease definitely increases with the PSA value. But one thing that's, at least anecdotally, I've found, and I think this is borne out somewhat by the literature, is that the sensitivity is clearly greater in higher initial grade and more rapid PSA doubling time. So in the patients where we have a very rapid PSA doubling time, I've seen very low numbers. Conversely, I've seen in patients who have a very low-grade disease, like a Gleason 3+3, biochemical recurrence since 2006, I've seen scans that are negative with PSAs of 8 or something like that. So there's definitely a negative thing that happens in lower grade biochemical recurrence. There are significant changes in management, but as we've discussed, in the long run, what is this going to do for the patients? And that's going to be difficult to sort out, and this is something that a lot of people are working on right now. So the next question is, what scan is best? And I'm not going to lie, this is not yet clear based on the literature. So what we do know is that all PET-based agents, including choline, fluciclovine, and PSMA, are superior in terms of sensitivity and specificity compared against CT and bone scan. And that's been documented in multiple studies. There are case series suggesting that fluciclovine and PSMA are superior to choline. And there's a very small case series recently reported suggesting PSMA is superior to fluciclovine. Okay, so this is I'm kind of going off the radar here. This is mostly my opinion, but it's supported by at least some of these findings in the literature, which is that CT and bone scan is less sensitive than choline, which is less sensitive than fluciclovine, which is less sensitive than PSMA, but PSMA is not yet routinely available. So this is my opinion of the current state of the art, and of course this is a very biased based on my own experience, so there's going to be plenty of other people out there in the field who have a different opinion. This next case is a CRPC case, and I think rather than going through the CRPC case is going to take forever to go through, and it's going to precipitate a long discussion. So I think probably the best thing to do is just discuss the therapy that this patient had. So this patient had a long treatment course with multiple prior therapies, including anti-androgen therapy, underwent abiraterone, docetaxel, with varying response, and then gradually with recurrent disease. And then this patient had significant metastatic disease confined only to their bones with no lymph node or soft tissue metastases. So this was a patient who was referred for Xofigo therapy, and in this case was, as part of a study, was combined with enzalutamide. And this is one interesting thing I've seen at our institution is more combination therapies being used with Xofigo. So this patient did have enzalutamide and Xofigo therapy, had a partial response on bone scan, no new nodal metastases, had a stable PSA for about a year, and then starting to creep back up. Just to summarize, it's indicated for prostate cancer metastatic to the bones. It's an alpha emitter, much more lethal than the beta particles we're using in a lot of our other therapies. The main thing we really worry about in these patients is the bone marrow suppression. The package insert requires a hemoglobin greater than 10 for first therapy, greater than 8 for subsequent therapies. Well tolerated in many cases, but that hemoglobin is really something you got to watch out for. And that has a survival benefit, as demonstrated in this Alsimca trial, which we discussed. So in terms of new therapies that are out there, so I'm going to just briefly go over PSMA therapy. So this is the theranostic concept, where just like how we have the diagnostic agent of PSMA, we can also have a therapeutic agent. And here we've used primarily lutetium-based therapy. So it's lutetium-177, which is a beta emitter. The way for this therapy was paved by a separate agent called lutetium-177 dotatate, which is called Lutathera, which was just approved this year for treatment of neuroendocrine tumors. And these theranostic PSMA agents, and they've been tested primarily in Europe and Australia, although there's now clinical trials opening in the USA. We're going to probably be up and running at UCSF in a few months. And here's just an example of what we know about these PSMA agents, and it's, the data is fairly limited, but this is a waterfall plot looking at PSA change from baseline in a follow-up of about 100 patients. So you can see there's a significant proportion of patients here who are having a PSA response to lutetium 177 PSMA. There's no phase 3 trial data yet available, though. Another potentially even more exciting for the long term is coupling the alpha emitter concept, which is using the more lethal form of radiation with PSMA therapy. And here's an example of a patient treated with actinium-225 PSMA. So this is now an alpha emitter. You're using the PSMA targeting and getting that alpha therapy in there. So you can see, and this is just one example, but a patient who had, bad CRPC, PSA of nearly 3,000, with, essentially a near complete response to therapy after a few cycles of this therapy. And here's another example of a patient who first underwent lutetium PSMA therapy, but in between panels A and B. You can see, looking at their Ganglion PSMA scan, the disease is getting worse after the lutetium PSMA, and then they got switched over to the actinium, and again, had a complete response to therapy. But I'll point out one additional thing to you, which is look at this patient's salivary glands afterwards. So this is that dry mouth thing that you were talking about. So, these patients probably had their salivary glands ablated. Okay, so that's essentially brings us to the conclusion of the program tonight. Just to summarize real quickly, a lot of interesting stuff out there. We're getting a lot of new imaging agents, a lot of new therapy agents. As you can see from this very lively discussion, we don't know what to do with these yet. A lot of interesting stuff is being found out, and the true survival benefits and all that of this is going to be learned in the years to come. But I think we're in a very exciting time for prostate cancer imaging and therapy. And so just to summarize, I'd like to say that we can add PSMA PET to initial diagnosis and staging of the high-risk prostate cancer. In the biochemical recurrence setting in appropriate patients, you can add fluciclovine and PSMA-based agents. And then for therapies for the CRPC patients, consider radium-223, and then potentially in the long run also PSMA-based therapies. Thanks very much for your attention.